Welcome to the King of the Hill Hand Hygiene Conference Call. My name is Sherry and I'll be the operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Deanne Richards. Deanne, you may begin.
Thank you so much, Sherry. And good afternoon. I'm Deanne Richards, and I'd like to welcome you to today's webinar, Still King of the Hill Hand Hygiene. It's presented by the Lake Superior Quality Innovation Network, also known as LSQIN. The Lake Superior QIN is comprised of three organizations: Enpro in Michigan, Stratus Health in Minnesota, and Medistar in Wisconsin, to support the Centers of Medicare and Medicaid Services priorities for healthcare quality improvement. We all know that healthcare organizations are working hard to make quality improvements in your facility to prevent and reduce HAIs, support the culture of safety, and improve outcomes. We hope that you will learn from what you have learned today will help you to be successful in all these efforts. This session is being recorded and will be available in about 2 weeks. The PowerPoint presentation is a WebEx handout and it's available under Event Materials. We'll remind you how to access this and our recording at the end of this session. All lines will be muted during the webinar, and we're hopeful to have questions and answers at the end of the session. So please make note of any questions you may have as you are listening, and then we'll respond at the end as a group. You may use the question and answer function during the presentation also, but just know that I'm not able to respond until the end of the presentation. Also, just so that I know that you're fully engaged, you're welcome to feel free to share thoughts in the chat function, as it's really hard to gauge your reaction when you're only looking at the screen at this end. With that, we'll go ahead and start today's presentation. And even as I start the presentation outlining the objectives, I'm going to apologize ahead of time. You're getting my Susan Koschut voice today. Just know that if you hear a momentary silence, I may have just muted my phone while I cough for a moment, but I'll be right back to you, as well as maybe taking a sip of tea periodically. As you can see from our outline today, I'm hopeful that we can review the elements of a successful hand hygiene program, summarize the current recommendations and common gaps and barriers, and explore possible interventions to increase compliance. You'll notice that I'm not going to be covering specific products or making such recommendations. As a Quality Innovation Network, this is not within the scope of our work to make these type of recommendations, and I need to stay neutral as it relates to products. I did want to share, though, that per the Economic Evaluation of Interventions for Prevention of Hospital-Acquired Infections, a systematic review that was published in January 2016, prevention programs for hospital-acquired infections have a very positive cost-benefit ratio. They reviewed 27 articles and found a median cost savings to cost ratio across all studies, reporting both cost and savings values of $5. And the median net global savings was $13.18 per month. So every effort that we put in to creating a successful hand hygiene project is something that we can actually add value to our organization. I don't think we actually have to talk about the value of hand hygiene because we already know how it is so effective across the whole organization and help lowering the chances of patients as well as our employees acquiring infections. But I wanted to ask you at this point in time, what is your challenge? Emily, could you go ahead and release the poll for me? You'll have an opportunity in just a moment for you to let me know what is your greatest challenge. Is it obtaining the administrative support you need to implement policy, procedure, protocols, and a program? Is it obtaining consistent observations? Is it engaging your staff? How about the compliance of the staff to actually follow those policy, procedures, or protocols? Or addressing barriers and gaps? So please go ahead and take a moment because we'll have 30 seconds then to go ahead and have those questions be answered. While you're doing that, I just want to remind you, I work with the Wisconsin Hospital Association, and every year they conduct an annual needs assessment and found in 2015 that 24% of hospitals who completed the survey did not have a formal hand hygiene program. The LSQIN also conducted a survey of partnering hospitals and found that between 12 to 18% wanted to focus on their hand hygiene programs. Of those, They found that the reason they believed that individuals were non-compliant within their organization, 7% of the time was due to urgent patient needs, 30% of the time it was due to just time in general, 7% of the time they forgot, 30% felt it was a compliance or accountability issue, 19% did not believe that the staff understood the transmission consequences, 7% felt it was due to incomplete observation data, 4% felt it was lack of instant reminders, 26% felt it was due to dispenser locations, 4% due to dispensers not working, 4% due to access of sinks, 4% for carrying equipment and supplies, 7% was due to staffing, and 11% used to gloves. Now, each facility is going to be different on really what that means to them. And as I look at the poll results at this point in time, it looks like for the majority it's the compliance of staff that is actually driving your difficulties within your program. So what is a successful hand hygiene program? Well, the last time we actually saw information was back in 2002, and that's back when they had indicated from the Center for Disease Control and Prevention that only 40% of individuals completed that. And they also listed the reasons they felt that this was occurring. We already know, and this is well supported by the Association of Infection Control and Epidemiology, also known as APEC, so if you hear me use that term, I apologize up front. APEC is the organization that helps infection preventionists and provides them with additional information, studies, resources. We already know that hand hygiene is a critical component of patient and safety for employees. We know that it's been accepted as the single most important measure of infection, transmission of infection, and it's the cornerstone of most infection prevention and control programs. The major shift on that focus back from 2002 guide was the introduction and promotion of alcohol-based sanitizer as a primary way for healthcare staff to decontaminate their hands. So what are our current recommendations and resources? The latest and greatest included the Guide to Hand Hygiene Program for Infection Prevention, and this is all available at the APEC website, which you have that resource at the very bottom that you can click that link or put that link into your web browser and pull that out. But what you will find was consistent with all of these is that there is no one magic wand. I wish I could give every single program a magic wand so you could wave it and have complete compliance and everybody follow and do exactly what they want. But instead, they're recommending multiple strategies all at the same time as the way to improve the standard, because single strategies are not likely to result in sustained behavior change. You may see something for a small period of time, but it is very difficult off of just one change having that improvement continue to improve. Recommendations from major public health organizations, regulatory standards, and professional societies advocate the use of multimodal approaches. The CDC and the WHO guidelines clearly delineate administrative responsibility for making improved hand hygiene adherence as institutional priority and for providing appropriate administrative support and financial resources. The Joint Commission's National Patient Safety Goal requires facilities comply with the WHO's or the CDC's hand hygiene guidelines. So please make sure that you know exactly which guideline you are following and you have that written into your policies and procedures. This lends additional support for the improved initiations to prevent the transmission of infection and improve patient safety. Recommendations for increased use of waterless hand hygiene products do not negate the need for hand washing sinks. The American Institute of Architects 2010 Guidelines for Designs and Construction of Healthcare Facilities address this issue by continuing to require hand washing stations defined as an area providing a sink with hot and cold water supply and a faucet that facilitates easy on-off mixing capabilities. This station includes provisions of cleaning agents and drying capacity. In addition, these guidelines require that there be one hand washing station in the patient's bathroom for the patient use and another hand washing station in the patient room. ideally near the door for the healthcare provider to use. Now keep in mind, these are 2010 guidelines. So if you have a facility or a unit that was built prior to 2010, that does not mean that you have to go back and retroactively change those rooms. The guidelines for AIA, which I just quoted from, actually are based upon the time in which your facility or that area was updated. If you do use the link at the bottom for APEC, you're certainly welcome to hit the search mechanism, which is in the upper right-hand corner of the page, and then type in the guide or tool that you're looking for also. In addition, CDC has many interactive web bases, as well as I mentioned, which is the World Health Organization, has a beautiful packet on hand hygiene materials as well as education. But again, I need to stress, education alone seldom leads to adequate adherence to hand hygiene in healthcare. Again, that multimodal or multidisciplinary strategies are more likely to lead to a change and improved hand hygiene practices. The CDC and WHO guidelines, as well as the Joint Commission, require monitoring of healthcare providers' adherence to the recommended hand hygiene practices, and that feedback is given about their performance. So, what's in your plan? I wanted to just remind you that many times in that learning pyramid, what I hear many individuals say is, we just need to teach them. Oh, well, they're not doing this, so let's go back and just teach them how to do that. But we need to understand they're humans. Peer lecture is only maintained and followed through 5% of the time. Even if we give them a reminder for something for them to read, 10% of the time will they actually retain that. If you have something audio and visual, only 20% of the time they're going to retain that. Even if you have them demonstrate the skill, that retention is only 30%. We don't start going up in the percentage of retention and that follow-through until we get to discussion of the group, which is 50%, practice by doing it 75%, and our highest outcome is if we actually create it so that the employees need to actually teach others or have immediately use of the skills they've learned. We don't automatically follow a written prescribed program of what to do, how, and when. Many times, I can say that when I have asked individuals what was the reason they did not perform hand hygiene, not a single person has ever told me, I don't believe in hand hygiene. So what are some of the different things that we can do? That's where we're going to head into next. One of the aspects we could look at is patient hand hygiene. Yes, there's been information out there for several years of asking patients to be monitors and auditors. And in the third bullet point, you can just see a number of programs that include. But there's also an area that I haven't seen many individuals look at, which is the patient's own hand hygiene. The patient-centered hand hygiene, the next steps in infection prevention, was published in 2012, but not many organizations have taken this focus. We already know that patients' hands transfer pathogens in the environment, have a direct spread to the healthcare workers. The healthcare workers then could transfer those germs to their hands and then disseminate it to other patients, all the time increasing their own risk of infections. But when we look at studies of patient hand hygiene, patients reported that only 50% of the time were they actually offered hand hygiene after using a commode, where 31% of patients say they were never offered hand hygiene. Even when we look at nurses of what they report versus patients report, 64% of nurses say they do offer hand hygiene to patients. But looking at that same clientele, only 15% of patients actually recall being asked if or offered. When you implement a program that supports the model of patient-centered care and includes the patient in the education of when hand hygiene is needed and how to perform it, they did feel that they were able to increase the patients that felt that they could actually interact and feel comfortable asking their nurses and physicians to perform hand hygiene. But prior to receiving that, 75% of patients actually didn't feel comfortable asking nurses or physicians to do that. Even when healthcare workers invited patients to ask, they still only reach the realms of 60 to 70%. I think the best example I have for you on this one is in a acute care hospital where I would work. We had a neonatal intensive care unit. Their hand hygiene compliance was 99.9. One of the reasons they had such a high rate of compliance was the fact that every new parent or family member that came in to see their infant or newborn needed to actually have education done by Julie. And Julie would ensure that every single individual went through the education with her, and she would check them off. They would have to come back and re-perform the hand hygiene again. And by the third time, she would say, okay, you're great. You can go right ahead and do it yourself and go in and see your infant. This allowed consistency of them understanding exactly what they needed to do, how to do it, as well as they could see and understand why staff would also follow those same rules, as well as they felt that they could indeed ask staff, I didn't see you clean your hands, could you do that? Or vice versa, that staff felt they had the ability to say, oh, no, before you open up that door, let's just go ahead and clean our hands. That way, the whole unit and the whole environment was focused on the cleaning of hands. So if we're looking at this aspect for patient hand hygiene, we actually need to determine what the timing is. And we need to make sure that the patients understand that timing also. So related to that, it would be after toileting, when leaving and entering the room, before eating, drinking, or taking meds, or after coughing and sneezing, much like staff would. Other things you may want to consider is before and after contact with visitors. And other things that can help you engage those patients include technique, education, and some type of promotion. Timothy Landers is the assistant professor at the College of Nursing at Ohio State University, sums it up with this quote. Patient hand hygiene is after pees, wheeze, please, leave, or sneeze. This way, the implementation of that process allowed staff to remember as well as teach them, the patients, of what to do. The only item I really wish is that they would come up with some very distinctive benefits to show me how much improvement occurs with hand hygiene by taking on this approach, but I think it's one that's still well worth looking at. Other areas that we could look at to help improve, increase that compliance, includes looking at the two types of challenges to change. First one being technical. That's defined as those that can be solved by knowledge of experts. They're easier than adaptive, as the what is only 20% of the change. Let's compare that to adaptive. Adaptive requires new learning. It's a greater part of the transition. It's more the how. And this is where the community engages in the process, overcomes resistance, and puts some new wisdom into this practice. Our goal really is that behavior change, and programming of behavior change includes some of these items. When you're looking at that behavior change, you first need to know, is it obvious to you what factors need to be addressed? So in hand hygiene, do you really know what needs to be addressed? I shared with you what facilities in Wisconsin felt, but it doesn't mean that we went back and were able to validate what the IPs felt were the reasons were indeed the reasons. The next area we need to look at is, if it is, then are you able to state what you want people to do? Now, most individuals can tell me, yeah, I want them to be compliant. But you need to be even more specific on that. Is it when I have when I have staff walk into a patient's room and they are carrying a blood pressure monitor, can you state exactly what you want them to do and how to perform hand hygiene? If you know that your behavior is objective, then you can work backwards and analyze all the factors that need to be addressed in order for that behavior to take place. So truly, if you know from your observations that staff are forgetting to perform hand hygiene when they walk in the room because they're carrying supplies, work backwards and determine, when do I want them to do hand hygiene? Where do I want them to put these supplies? How do we address that gap in between the time they walk in and that moment of silence where the patient and family members are waiting for them to do something? Let's explore further different modules of behavior change. So the first one I have for you is precede and proceed. This is an educational diagnosis which processes that a target behavior, and you state it as a behavioral objective. And you want to start by looking at the factors. And these factors are sorted into 3 categories. The first one, the predisposing, will help motivate people to make a change. It's much more on factual information or supportive attitudes, beliefs, and personal values. Now, those attitudes, beliefs, and personal values are difficult to change. To do that, we use education and communication strategies to establish factual understanding and build attitudes that will help people to begin the change process. The second, enabling. Once motivated, capacity to change is based upon, do they have the necessary skills and capacity, and the third, resources. For hand hygiene, do they know how to perform it? Do they have the required supplies to perform it? If this is for the patients or visitors to carry out hand hygiene, do they have readily access to the hand sanitizer or the instructions? If you're providing the necessary training or resources, can you improve any other enabling factors? And the last one is reinforcing. The impact occurs after the targeted behavior has been initiated, and it determines if it will continue into the future. Another model that we could be looking at is social cognitive theory. And I'm sure that this diagram is not new for some individuals, looking at the triangle between the person, behavior, and the environment. This really is the interaction of behavior also. The person, their knowledge, their temperament, their internal motives, and their skills. So when we look at that person, again, we need to look at their motives, their knowledge gaps, attitudes, skill levels in multi-phase ways, methods, places, and time. When we look at the environment, we need to look at physical, social, organizational, but also we want to look at peer support, prompts for the patients, role modeling, compliance initiatives. All of these things will affect the change of behavior. The next area is on trans-theoretical model or stage theory. One of the things we need to look at within this theory is readiness. The unawareness that change is a desirable option where others have already completed the change but are at risk for reversing their progress or relapsing. So this might be where you initiate a whole campaign with hand hygiene, create a lot of awareness, you see your compliance go up, but then you see it fall after your program is done. There are things that we can look at, such as pre-contemplation. That's the I won't. That's the unawareness. There's no desire, no reason. And I'm sure in your mind you can think of those individuals that fall into the I won't category. Then there's contemplation. That's the I might. So they weigh change by looking at pros and cons. Then we can look at the preparation. Those are the I will. That's making plans to change their behavior. Then we can move into action. That's the I am. So you're currently adapting and adopting to that change. And that last level is maintenance, the I have. That's making change and avoiding relapse. This is a great time to use a questionnaire or a focus group that can be used to assess the perceptions and practices regarding a recommended action. And it can be used to tailor an education approach to meet the level of stage of readiness. I have had groups where I brought them in and we started talking about hand hygiene and what prevents them from actually performing hand hygiene. Rarely do I get to the I won't, that I won't perform hand hygiene. Many times there's misunderstanding or thinking that hand hygiene is not needed when it really is. And by having a group discussion, I prefer that the group come up with their own solution and they figure out what's wrong with a current practice they have. Because it's much more likely you will have change if it comes from a peer versus the individual they perceive as a leader or somebody they consider as a sheriff with this. Another model of change is positive deviance. Now, positive deviance is a behavior change approach that's based on observation, and that occurs in a community where there exist individuals who have found uncommon practices and behaviors that enable them to achieve better results than their peers, despite the similarity of the problems and available resources. In your head, is there a unit that's doing really well on hand hygiene? Have you gone to that unit and actually sought out what they're doing differently compared to other units within there? One of the key principles of positive deviance is that the community must own the entire process. They must discover the uncommon successful behavior and design ways to expand them into common practices that are used consistently, monitoring their own progress. Positive deviance emphasizes practice instead of knowledge. It's the how instead of the what or why. The positive deviance mantra is, you are more likely to act your way into a new way of thinking than to think your way into a new way of thinking. Positive deviance methodology consists of 5 basic steps, and that's where you get your 4 Ds and your 1 M. These comprise of a roadmap to the process. So the first step is to define the problem, current perceived causes, challenges, constraints, common practices, and desired outcomes. The next one is to determine the presence of positive deviant individuals or groups. The next is discover. You're trying to discover uncommon but successful behaviors and strategies through inquiry and observation. The fourth is design. Designing activities to allow community members to practice the discovered behaviors, and the fifth being monitor and evaluate the resulting project or initiative, which further fuels change by documenting and sharing improvement as they go. With positive deviance, probing questions is a great way to find out what's going on. So here's just a couple that you could be using when you're finding that you have somebody who's highly successful on consistently following through and performing hand hygiene. So it could be something as simple as, what do you do when you are carrying multiple things into the room? How do you handle that challenge? And allow them to talk and share what they know or what they have already figured out. And I did include on the bottom there a link so that if you would like to see more about positive deviance, you can do a little more reading also. The next area that we could look at behavior change is on learning and behavior science theories. There are common general principles, and these include representatives of target groups into your planning. That includes promoting ownership and reasonability, providing insight into what might be effective. It also includes plans for cultural diversity. This may include addressing culture outside of the mainstream. Included in that is repetition of concepts and tools, and that repetition over time with various instructional or communication tools will enhance learning. Another item to look at is active learning. Don't rely on one-way dissemination of information, as well as look at mastery of enhanced learning. So look at learners, what they need to know, and make sure that they understand why they need to know it, and are they meeting expectations, and do they have strength in their competency to perform it? The final area is the multisensory learning. This is considered the most effective way to learn because it incorporates visual, auditory, and sometimes taste, touch, and smell. That's why, first of all, many of us that we use products in which we're actually dyeing the hands or putting a substance on the hand, and then having them perform hand hygiene with traditional soap and water, and then looking again to see if that product's there. Now, besides just doing it that, you could actually incorporate the step of applying the product, looking to see how well they spread that product across the hand, because that's a great way to simulate using a hand sanitizer. So you can see, are they actually getting that non-dominant thumb, which is one of the most missed areas, when applying either soap and water or the hand hygiene, besides looking to see how effective their traditional soap and water hygiene is. So the next one that I have for you is influencer. Now last month I gave a presentation which included information on the influencer book. Let's look at these concepts a little bit more using hand hygiene, and I'm going to switch my screen here, so if you will just hold with me for a moment, we'll do that.
What you're about to see is real. Real kids doing real things. Just thought you should know. My name's Hiram Grant, and I was there for... So here's a question. What does it take to get people to change? And I'm not talking about their socks and underwear, but change behavior, especially when it's hard. For example, every year close to 100,000 people die from hospital-acquired infections. That means people got sick at the hospital. And it turns out one of the main culprits is hand hygiene. That means just getting people to wash their hands could save lives. So my crack research team decided to conduct an experiment to see if we could change something as difficult as hand washing habits, only with the toughest subjects of all, kids. So here's what we did. We took 80 munchkins and put them into groups. First, we gave them a challenging puzzle to put together. You know, kind of like the projects you adults are always busy with. Then, we gave the kids a tempting distraction.
I got some cupcakes for you right here. Right over here.
Once I see that you guys have put the whole puzzle together correctly, I'll raise my flag, just like this, and then I'll blow my whistle. Okay? And when I do that, you guys can all go and get your cupcakes. So what would it take to get these kids to wash their hands? How about a good reason? So one thing you guys should know, there was a sick kid in here playing with the puzzle pieces. He had a runny nose and coughed a lot, so there's probably a lot of germs on everything. But there's hand sanitizer over there on the table that you can use to wash up. Okay, which will win out? Delicious frosted cupcakes or the fear of the typhoid toddler? Let's watch. They finished their task, and look, if the threat of one sick kid wasn't enough, just look at all the new germs popping up. So with all those good reasons to wash, what do you think they'll do? Okay, so that was a colossal failure. Now what? Well, at this point, most adults would quit. That's why you just keep changing the year on those New Year's resolutions. With the next group of kids, I changed the environment by moving the hand sanitizer closer, and then put up a visual cue. This ought to make hand washing easier and more obvious, right? And in the end, the motivation to not get sick plus changing the environment didn't influence a single kid. Yikes! Next, I increased their ability, which is another source of influence. I had them all complete what is known as deliberate practice, or training, to increase their familiarity with good hand hygiene. Will adding another source of influence get these hand-washing offenders to wash up? And... well, now we're seeing some better results. We're combining 3 different sources of influence, and some of the kids are actually washing their hands. It looks like we're on the right track. So next, I added another source of influence, social influence. What if somebody spoke up and said something? What would happen if their bosses were in the room with them? Here come the cupcakes. And there goes the flag. Will they wash? No! Look at them pouncing on those cupcakes like a pack of ravenous hyenas. But it's not too late, because something important happens. At just the critical moment, a peer, not even one of the bosses, speaks up. Wash your hands. What's the effect? Success, at last! So social motivation obviously made a difference. But was it the only thing that mattered? What about our other sources of influence? Here's what my kids had to say.
I was walking over to get my cupcake, and then someone said, wash your hands, because this boy has nipples.
So what's the point? We often underwhelm overwhelming problems. We try a couple of things, and when they don't work, we give up. But my dad and his colleagues discovered the secret to overcoming tough problems. You need to combine at least 4, preferably more, sources of influence. And it doesn't matter if you try it with kids, or hospitals, at the office, or even at home. If you use 4 or more sources of influence, your chances for success go up 10 times. 10 times! So there it is. The key to changing almost anything is to marshal the power of at least 4 or more sources of influence, but preferably all 6. And heaven knows, we need it.
Well, I'm hoping that you enjoyed that video. Let me see if I can turn it off so you don't have to hear the next thing on it, though. And let me go back into our presentation today, which unfortunately it looks like I may have just lost our presentation. Sherry, can you confirm with me that we've lost the presentation? I'm not hearing Sherry on the phone, so what I'm going to do is...
Sorry, is that, see, Emily's doing the WebEx? Emily confirm that?
Looks like I possibly have lost my presentation. So what I'm going to do is just pick it up on my end, sharing my screen, if that's okay.
Okay.
So bear with me, individuals, while I just advance to where we need to be. So as part of that influence, and I don't want you to go run out and buy the book, what I really felt that it helped me do is really look at how we change and what that occurs. So part of that convincing is convincing others to see the world differently, and it isn't easy because these 2 views, a person will have to try to enact new behaviors or stop one, and you're doing a lot of verbal persuasion. And let me actually get it so that you don't have to see my notes at the same time. Okay. Also with that, you've got your stories. And stories are very important. That at the last Association for Professionals in Infection Control and Epidemiology, our last closing session was on stories and how to use stories to your benefit. Because they actually know that stories actually are more rememberable and individuals are more likely to act upon a story than based on just pure data. And I even know for myself, when I would teach hand hygiene, I would always talk about the story of me finding a study and it indicating one spot that was most likely missed, and me running to that bathroom, performing hand hygiene, and going, yeah, you know, that study's right. I do miss my left thumb because I'm right-handed. And I will do all my work of doing my hand hygiene with my right hand more than my left, and that left thumb hangs out there. As well as I'd share the story because, Even in my previous job, I did much traveling across the state of Wisconsin, and I would stop at a local gas station to get my beverage as well as go to the bathroom while I was in transit. And having to deal with paper towel dispensers, which you have to push the button and then turn the crank, and how you can approach that differently with either pointy elbows or hitting that and rolling and getting enough paper towels in before you started to use the restroom. So sharing those stories, that I would have new employees come back to me and tell me how much they enjoyed those, as well as how they shared and had discussions around their family table, just talking about those stories that I had. But we need to make sure that the narrative helps listeners transport themselves away from the content of what's being said and into the experience themselves. And they are more understandable than lectures, and they can be more focused on simple reality than on the actual event. They're often more credible than simple states of facts, and stories create empathy reaction that just feel as real as enacted upon behaviors themselves. These works help you clearly define the links between current behaviors as well as existing or possible future or negative behaviors. It includes the positive replacement behaviors that yield new or better results. So let's look at what those sources were that they talked about in the video. Personal motivation is connecting vital behaviors to intrinsic motives. Personal ability is to coach specifics of each behavior through deliberate practice. Social motivation is the power of others to motivate and enable the targeted behavior. And social ability is what we need to do to assist each other to succeed. While structural motivation is the approach appropriate for the reward structures to motivate people to pick up at the vital behaviors. And finally, structural ability, to ensure that systems, processes, reporting structures, and visual cues support the vital behaviors themselves. All of this is part of deliberate practice, which is very important as part of an influence. Demand full attention or brief intervals. Most people can only maintain a heightened level of concentration for an hour max at straight time. Provide immediate feedback through clear and frequent feedback is much more effective than numbers or by hours of practicing a skill. Also, when you break them into many goals, you can concentrate on the controllable parts of the process. As well as for setbacks, you can build into resilience and gradually introduce tasks that require increased efforts and persistence. And finally, building those emotional skills. You can focus off of those distractive activities. If they are getting distractive, wait 15 minutes. That may be just a break, and then have them go ahead and come back into what you're focusing on or what you need them to be doing. As part of the deliberate practice also, we want to harness peer pressure. You want to look at avoiding the ridicule, but increasing the praise. Having exception versus rejection, and approval and disapproval can do more to assist or destroy or change efforts than most any other source. One of the common items I would do when I was in my last facility is I would do the simple rub my hands together as I saw individuals come out of the room, just as a visual to let them know I didn't see them perform hand hygiene. And most of the time I got, and they would immediately turn around, pivot, and use that hand sanitizer. But I would also, on the same thing, is that I saw individuals coming out of patients' room that were still rubbing their hands. I would say, thank you for being a great hand hygiene individual. So they received benefits both ways. They knew that I would always notice if they were performing hand hygiene, as well as I would consistently remind them if I did not see that. Also know the power of one. Do you have one respected individual or model or individual who always does this? That one person can be very beneficial for your engagement of hand hygiene. And enlist that social support. So find the opinion leaders that are key to everyone else. Think of it as who influences you. If there's an individual who's influencing you, they are also influencing your employees within your facility. Make the undiscussable discussable. Having discussions with your employees really helps seek healthy dialogue rather than have silence. Because we all know that we can't be silent about preventing infections. We actually need to have that discussion of what's preventing them from following through. Another item to look at is opinion leaders, and you need to become one. Opinion leaders are viewed as being knowledgeable about issues at hand, and they're trustworthy. They have other people's best interest in mind. And finally, create a village. People must be plucked from their support structure and placed in new networks if there is to be virtually everyone following in the same circle. Because by being in the same circle and all of us having the same goal, we support and reward the right behaviors while looking at the wrong ones to figure out what is indeed going on. Finally, within deliberate practice, we know that we can find strength in numbers because we can produce a force greater than the sum of all our individual efforts, kind of like the Beatles song, with a little help from our friends. It's a great time to have everyone look at it when there are parts of the problem which there are many involved in. Also, anytime there is something that you can't succeed in your own, get a little help from your friends. And finally, when facing challenges, turbulence, or novel times, it's a great time to look and have others help you through it. Because really, sometimes we actually need an outside pair of eyes. That's that blind spot. So maybe we need to have somebody else look at the problem, and maybe they can see something that we haven't. And the last one, designing rewards and demands accountability. That's like the culture of safety. We need it to be well-balanced. We need a change effort, but the rewards come third. We want the satisfaction to be first and the social support to be second. So those cupcakes, yeah, they're a reward, but they're a third reward. They're not the primary award. The last item I wanted to highlight was highly reliable organizations. And the best one I had actually seen on this just came out in January 2016 in the Joint Commission Journal on Quality and Patient Safety. They actually looked at a hand hygiene program that was based on Memorial Hermann Health System, in which after they implemented this program, their hand hygiene compliance improved by 37 to 35 points between a baseline compared to the end of the phase. And they had a relative increase of 65%. So they went from 58.1% compliance up to a 84.4% after the initial phase. They increased that all the way up to 94.7% in 13 months of the control phase. And in their final 12 months, they reached 95.6%. They also found that in their ICU, that their central line associated bloodstream rates decreased from 0.83 per 1,000 device days down to 0.42 in the last part of the control, as well as vent-associated pneumonia went from 4.04 per 1,000 vent days at baseline down to 0.57 during the improvement phase. And the only aspects they were doing was maintaining and improving on their hand hygiene. Highly reliable organization maintains high levels of quality and safety over a long period with very few adverse events. And the ultimate goal for hospitals and healthcare systems striving for highly reliable zero harm for patients. So within this, they looked at how could they identify and be effective and create reliable strategies for collecting their hand hygiene data, as well as what was the root cause and contributed to that noncompliance, and how could they implement specific interventions to address each one of those. Well, their very first thing they did is they used robust process improvement, which includes Lean, Six Sigma, and change management. Within that, they used a targeted solution tool that mirrors the 5 stages of Six Sigma. So they divided the timeline into 3 main periods. They had a baseline, which included collecting data in compliance before the implementation of the improvement. They had their improvement phase, as well as they had their control phase for specific improvement actions, and they used to actually promote their unit improvement. So there was a project lead. That project lead was indeed a black belt in quality, patient safety, infection control, and a chief nursing officer served as the executor and was the sponsor. So you can see for their step 1, they started at getting started. This started in October of 2010 and continued through the entire project through December of 2014. All the process owners, operational, were hospital managers, directors, or executives rather than members of quality or infection control departments. I know as infection preventionists, we always feel that hand hygiene is ours, we need to take care of it. They found it was much more effective by using others outside of quality infection control to help lead these projects. So the very first thing that they started in October 2010 is determine how to address and actually figure out what were those contributing factors. Now notice they didn't guess, they actually had to figure out what those were. But first, before they could do any of that, they needed to get started by finding those lead process owners, deciding on unit process owners, and then setting their goals and objectives as well as the timeline. Their step 2 was actually to train those secret observers. The secret observers were to observe and collect. They didn't interfere with any caregiver work. If they could see what was the reason for it, they would actually record that. They also had to have training videos, and they actually had to test out, and they had to have a score of 90% or higher on their certification exam, as well as they were trained in how to watch for factors that could prevent an individual. So they were trained to always look to see what were in the hands, whether their hands were full. They were trained to check to see if dispensers were broken. Only the secret observers their observations were used and recorded to calculate the non-compliance rates. They also had just-in-time coaches. And I will say, for those secret observers, they had to remain secret. If somebody found out that they were actually an observer, they no longer could observe. But for the coaches, they would engage staff that they saw non-compliance occurred. And they would help actually coach them real time at the immediate time. But their information related to did they wash or did not wash, that wasn't included within the final statistics. So there's step 3. And this ended in 2013. At the end of their observations, they had 31,600 observations for their baseline compliance. But what they set up is 20 observations per day for 14 non-consecutive 24 days per unit. Included all the shifts. It was just a paper form. It did not include visitors, and it did not include emergency situations, and it purely only looked at entry and exit. Their 4th step, including determining the factors. And minimally, they wanted to have at least per unit 30 minimum, but they really ideally wanted at least 50 observations. And what they found is they had 6 that accounted for 81% of the non-compliance. And that's what you're seeing there. So the improper use of gloves, frequent entry and exit, distracted or forgot, following a person during their entry or exit, their hands full of supplies, or ineffective or inconvenient placement of sink dispensers or sinks. Their 5th step included actually looking at the implementation solutions, and actually each unit had to come up with their best way of impacting that as well as making recommendations. So things such as distractibility. Some units developed code words to remind individuals to perform hand hygiene. For the placement or the dispenser of sinks, they would actually look as a group and make recommendations for relocations or where to add dispensers. If they forgot what was a good visual cue, as well as hands full, they actually added surfaces to actually put items down to allow hand hygiene to be performed. And in their sixth step, they actually looked at how can we sustain the gains. They didn't want to fall backwards. So they decided on minimum levels of review, as well as they maintain observations per month, and if they found that their rates actually went down, they returned to having just-in-time coaches to find out the reason. Their critical success factors included the fact that they had leadership support and oversight due to resources. Although it was led by that master black belt in lean, that they really encouraged the implementation even if you do not have this resource within your organization. Because of the perceived urgency in identifying and addressing problems and not wanting to rush through the entire process and skip those 3 steps, which was getting started, the secret observers, and just-in-time coaching, as well as coming up with a measurable baseline, that is so key before you start implementing your improvements. And finally, you need to completely define the problems and ensure accurate measurements to get to the root cause, because I know a number of times when I'd be presenting hand hygiene data, the staff just wanted to argue the data rather than look at what was potentially causing that from occurring. So one of the things that we've done here at LSQIN is I try to combine a multitude of these approaches all together. And if you go to the website that's listed here, you're going to find 2 resources. The very first one, which is that top arrow, is actually Team Steps, which is a method of communication. In that, you will find, such as cups, on a great way to intervene. So if I see Terry walk out of a room and not perform hand hygiene, I can say, Terry, I'm concerned. I didn't see you perform hand hygiene, and I want to make sure that you stay safe as well as your patients that you're going to take care of next. So it kind of walks you through different ways of communication. The other one that I'm even more excited about is the hand hygiene observation tool. That is actually an Excel spreadsheet based upon that last tool that we looked at, but not only does it give you items that you can do the definitions, it gives you the observation sheet, it also gives you a form so you can actually put your data into it, and it will auto-calculate your rates. It will break it down into overall information, including your coaching and your observers. It will also include just your observers, and it will break it down to your non-compliance and where that's occurring, including right down to the shifts and units. And I know I'm talking really fast because, in summary, only by doing multiple approaches can we really address hand hygiene. And we need to engage all the frontline staff. This is not an infection prevention problem. This is an organizational effort, and we need to take advantage of all those resources, including every frontline staff, to find out what's going on and how we can make that better. And by utilizing those theory-based tools and process, we can create and sustain a change. I also want to remind you that the World Health Organization, our May 5th, 2016 slogan for hand hygiene is here in this image. And we want to make sure we send a consistent message across the world that hand hygiene is important to us. At this point in time, Sherry, I know we have run out of time. I'm hoping that there are some good questions on chat or in question and answer, and what I can do is send those answers directly to you. But could I have you go ahead and release today's evaluation for today's webinar? While that's occurring, please note that you do indeed have my contact information, and you're quite welcome to contact me. Just note that even though my last name is Richards with an S, that in my email it does not have the S in there. But I would be glad to share any additional information and help you through this process because, again, it's one of those things that I really want to make sure everyone has the tools at hand to have a successful hand hygiene program. Thank you so much. Have a great day.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.